Welcome to tonight's webinar. My name is Allie Armstrong. I'm a field marketing specialist for Axonics Therapy and will be moderating this webinar. This evening, Dr. Fisher will be speaking about bladder dysfunction, the common symptoms patient experience, and treatment options that may help you gain control. Without further ado, I would like to introduce Dr. Fisher.
Allie, thank you so much, and good evening, everybody. Thank you for taking the time to join my webinar. I'm very excited to take this opportunity to teach you a little bit about overactive bladder, urinary dysfunction, and overall symptoms that really create a lot of bother in people's life. So first thing I want to do is just tell you a little bit about myself. So my name is Dr. Robert Fisher. I'm a urologist with Georgia Urology. I practice in both the Lawrenceville and Braselton area. And my specialty includes general urology. So I really see everything from cancer to complex kidney stones and large prostate, erectile dysfunction. But one of my main specialties is dealing with overactive bladder and urinary incontinence. And included with that is a lot of different new technology and procedures that can help these conditions, such as axonic sacral nerve stimulation. Now, a little bit about my background. I have a non-traditional background. I actually, when I was 18, I was not quite ready for college. So I actually decided to enlist in the United States Army, and I joined the Army as an infantryman. This was during when Iraq and Afghanistan were going on. So I wanted to sign up and serve my country. So I did 4 years in the active duty Army. I was stationed at Fort Lewis, Washington, and actually trained in Fort Benning, Georgia. And then ultimately I went to Kandahar, Afghanistan for a year. During that process, that's actually where I figured out I wanted to be a doctor. I had no idea when I joined. I just really wanted to join to serve my country, see what I could do to help, and then figure out what I wanted to do with my life. And then after that, my plan was to use the government benefits, the GI Bill, to go to college and do whatever it was I figured out. So basically, I served my country, and then after that, I figured I wanted to go to medical school. So when I got out, I went to college up in Washington State, which was where I was living at the time. At a school called Pacific Lutheran University. I spent 4 years there studying science, and I graduated with a Bachelor of Science in Biology. From there, I went on to medical school, and I went to St. Louis University in St. Louis, Missouri, and I did 4 years of medical school there. And then after medical school, I went to train in San Diego for urology residency. I ended up picking urology. A lot of people always ask that because urology is it's kind of a fun field because it's a lot of surgery and a lot of clinic. You get to work with people. And the thing I really like about it is that we use a lot of technology to help people. So I do a lot of robotic surgery, lasers, and doing things like, nerve stimulators and, things like that. So I really like the technology. And then the other thing I really like about urology is that the conditions in urology are often very treatable. For example, I used to get frustrated as a medical student when I would treat something that was hard to treat or had a bad prognosis and such forth. But with something like urinary incontinence, there's a lot of treatments we can do that really change people's life for the better. So I really enjoyed the satisfaction of being able to truly help somebody. So that's just a little bit about my background. Now, this is just a slide on some, safety information, basically talking about the indications and contraindications to the axonic system, which I'm going to talk to you a lot about. But the idea is the indications really are for, men and women that have overactive bladder or urinary retention with or without incontinence that have failed other therapies, which we're going to kind of talk about. And it also has a role for fecal incontinence as well. It's really for people that have tried the therapy and who have had a good, response. So basically, we're going to talk about some of the things that are the indications and whatnot, but these are some of the specific things. We're also going to kind of talk about the precautions and what the system does, how it's implanted and so forth, and what some of the potential side effects are or risks that come with it as well. Now, basically, the main reason this whole kind of therapy comes up really comes down to quality of life. And this is one of the things I always ask people when I see patients in the office with urinary symptoms. I always ask, how are these urinary symptoms bothering you? How is it messing up your life? And here's a couple examples here. Some of the common themes people tell me is they'll tell me that every time they go anywhere, they have to know where the bathroom is. They'll say they can't go on a long drive without knowing where they can stop. Another thing I commonly hear, especially from women, is I'll ask them if they leak any urine. They'll say, "Oh yeah, I do, but that's normal." Those are some of the kind of bladder and bowel symptoms that can be very common that I'll see for patients that I'm concerned with for overactive bladder. Now, the main thing I want to tell you is this is a very common problem. Overactive bladder affects a huge portion of people, people that realize it or not. And really what it comes down to is if you're someone who's bothered by your urinary symptoms, then you're affected, and you're someone who is a potential candidate for some type of treatment. And we're going to go through all the different kinds of treatments, not just the axonics therapy. So just telling what I kind of said, it's the data shows is 50 million people in the United States. So as you know, the US population is over 300 million. So that's still, 1 in 6, 1 in 7 people are affected. And a huge portion of that is also people that have fecal incontinence, which that's something that a lot of people struggle with. And this has a strong opportunity to help those patients. Key thing I want you to notice on this slide is that it says only half of people with severe symptoms seek treatment. And that's what I'd like to urge anybody with bothersome symptoms, severe, anything that's bothering your quality of life, is you should get treatment, because this is one of those things that there is treatment available for. Now, next, I want to go through and kind of just explain a little bit about what the condition of overactive bladder and urinary urgency and fecal incontinence is, okay? So basically, overactive bladder is like a constellation of symptoms. It's not like one of those things you can't do a biopsy and diagnose overactive bladder. Overactive bladder requires a doctor to evaluate your symptoms, do some tests, and determine, clinically, I'll say, okay, you have overactive bladder. Some of the symptoms of overactive bladder involve urinary urgency. So that's where you get a strong urge to urinate. So a good example I often ask patients is, do you ever feel like if you were driving, you would have to pull over the car to go to the bathroom? Like you couldn't even wait till you get to the exit. That's an example of urgency, where you feel like you have to go, and if you don't make it, you'll have urinary leaking. Another symptom of overactive bladder is urinary frequency. A person on average, should be going about 4 to 8 times a day is probably normal. Some people a little less, some people a little more. But if you're going over 10 times a day, that's urinary frequency, and that's a big part of overactive bladder. You shouldn't be going to the bathroom every hour. Overactive bladder often involves urinary incontinence, specifically with urgency incontinence. So that means when you get that strong urge I talked about, that you actually have leaking of urine with that. And obviously that can be very debilitating to quality of life. So that's a little bit of what overactive bladder, the symptoms are. For urinary retention, this basically means you don't empty your bladder all the way. So urinary retention can actually mean you can't urinate at all, and you have to actually use a catheter or something to empty your bladder. But it can also mean like you just don't feel like you empty all the way, or you empty half the way, so it means you have to go more often. And that can be from conditions like diabetes or different neuropathies, different kind of problems, but that's something that's a common problem we deal with as well. And then fecal continence, that really has to do with you feel an urgency to have a bowel movement, and again, you can't make it, and you have sort of stool in your pants. So that's what fecal incontinence is. Now, the way the bladder is supposed to work is the bladder, you need to think of it like it's a stretchy muscle, okay? It's supposed to basically stretch to fill urine. So the idea is when you drink water, your kidneys make urine, and then that urine goes to your bladder, and your bladder should fill. And then once you get to a certain point, your bladder is supposed to signal your brain through nerves that says, okay, I'm full, I need to go to the bathroom. And then when you get to a socially appropriate time, meaning you get to a bathroom, then your brain tells your bladder to squeeze, and then also relax the sphincter. That's what holds urine in. So you squeeze the bladder, relax the sphincter, and then you urinate out at the appropriate time. So that's the way it's supposed to work. Now, like I talked about with the overactive bladder, this is the constellation of symptoms. When your bladder's kind of, the nerves or the bladder itself are sort of overdoing it and basically acting on its own without the sort of brain, meaning you, controlling it. So again, the ones I hallmarked are urinary frequency, urinary urgency, urge incontinence, and then nocturia too. Nocturia means going to the bathroom at night. And that means, it's okay to wake up one time a night, but if you're waking 2 or more times in an 8-hour period while you're sleeping, that's definitely a symptom of the overactive bladder potentially. And the other important thing about overactive bladder in that situation with nocturia is that, if you're waking up 2, 3, 4 times a night, then at nighttime is often a dangerous time to wake up if you're tired, because that can lead to people falling, getting hurt, restlessness, being fatigued during the day. So that's actually a lot more debilitating than just the urinary symptoms. Now, kind of alluding to what I talked about earlier, the way the bladder is supposed to work is when it's full, it tells your brain you need to go. And then when you're ready, you basically release the bladder and urinate. Okay. So an overactive bladder, the bladder will sort of get the sensation and squeeze on its own without your permission. And that's really what urgency is. So with urgency, it's your bladder actually squeezing. And this is something we measure on tests. And it shows that basically that squeeze causes urine to try to come out. And urgency is just the squeeze. And if it actually leaks out past the sphincter, that's urgency incontinence. So that's a hallmark of overactive bladder. And that's exactly what that is. So it's really like an abnormal nerve connection between the brain and the bladder. Now, urinary incontinence is not just urgency incontinence. There's really kind of a few different aspects of it, and alluding to here. So we've talked about, looking at the right side of this diagram, overactive bladder, which may or may not include urgency incontinence. Then on the left side, you'll see there's stress urinary incontinence. So stress urinary incontinence actually doesn't have anything to do with bladder function. For the most part, it has to do with the sphincter. Now, stress incontinence is much more common in women, but it does happen in men sometimes, especially if you've ever had surgery for prostate cancer. But for women, what happens over time is the pelvic floor tends to weaken as you get a little bit older, or if you've had children, or many other risk factors. And when it gets a little bit weaker, if any kind of stress is put on the bladder, meaning like a cough, a sneeze, exercise, moving a certain way, that type of thing actually pushes on the bladder. And if your sphincter, the thing that holds urine, is weak, for whatever reason, that can make urine leak out. So that's what stress urinary incontinence is. And that's different than urgency incontinence. Now, a lot of patients can actually have both. And I see a lot of men and women that have both type of incontinence. And that's when it's called mixed incontinence. Mixed incontinence means you really need a urologist to help you do some evaluation and take a thorough history to really help you understand exactly what type of incontinence you may have. Now, just to go over briefly about bowel function, and you may ask as a urologist, what do I know about bowel function? Well, believe it or not, we actually do a lot of bowel stuff. We do surgery on the bowel, and, we treat this type of condition. But, the bowel kind of works very similar to how the bladder works in a lot of ways. As the rectum fills with stool, as your body digests the food you've eaten, basically that causes a stretch sensation in the rectum. Then the rectum is the area right before your anus, where you would have a bowel movement. And basically when that stretches, it sends signals to your brain. And then again, and that tells you have to go. And then once you get to an appropriate time, brain tells your bowel, okay, it's okay to go to the bathroom. And it causes squeezing of the muscles and also relaxation of the pelvic floor to have a bowel movement. Now, fecal incontinence, again, is uncontrolled loss of stool. So this, again, usually includes feeling urgency, where you feel like you have to go and you just can't make it and it leaks out, or where you feel that urge and it may or may not leak out. Either way, the urgency is irregular. And then also some people can have just leakage of stool without even notice of the urgency. So those are types of things of fecal incontinence. Now, this is really what's important, is, again, what I said in the very beginning: how does this impact your quality of life? And this is, what I would tell you. If you're someone who has, you have a small leakage urine one time, every 2 months, and it's not a big deal, that's not really impacting your life. But if it's causing you to not be able to do many things in your life, then that's where it is. If you can't do certain things, if you can't do soccer practice with your kids, if you can't go out in certain social settings because you feel like you're going to smell of urine, or if you can't go on a long drive, if you basically have trouble going to work, if you feel like you have to wear pads or diapers, or they're expensive, or you can't wear certain type of clothes, these are all things that affect your quality of life. And that's when you really should think about, maybe I need to get some evaluation to help me overcome these symptoms. Now, this is a very important part. I think almost the hallmark that should help you understand if you need to get evaluated or not. If you have these symptoms, it is not just a part of getting older, like this says. It's not, all women are not supposed to have these symptoms. They often happen for women, but that doesn't mean you just have to live with it. The other thing is, a lot of men with urinary symptoms often get their symptoms blamed on the prostate, when actually it's overactive bladder. And it's also, it's not a result of something any patient did wrong. This is something that often happens on its own without any kind of initial cause. It's sort of spontaneous, and it's something that you deserve to have treated. Now, I want to go through next and talk about all the options, because there's a lot of options we have to treat bladder and bowel symptoms, and I basically offer all of these things. And each different option is great for certain patients. So I'm a big believer in finding the right therapy for the right patient. So I'm going to go through them in detail now. So basically with overactive bladder, the first things to know is that, when I see a patient, I take a thorough history, figure out exactly what the symptoms are, how long they've been going on. Basically I like to do some evaluation. I like to get a bladder diary in a lot of patients. A bladder diary is something where I ask you to kind of record for a couple of days, how many times you're urinating, if you have how often you're having urgency, how often are you having leaking. So I try to get a good, sense of your symptoms, and I often do some tests like a bladder scan, a urinalysis, sometimes other tests if I can't tell what's going on. Then once we've kind of figured out, okay, you probably have overactive bladder. Key thing for me is I like to do lifestyle changes, which commonly includes pelvic floor physical therapy. I'm a big believer in pelvic floor physical therapy, and I actually have a lot of patients, men and women, that I send to pelvic floor physical therapy, and it helps significantly. A lot of people don't need any other treatment other than that. And basically what pelvic floor physical therapy is that you go to a specialist, which helps strengthen the pelvic floor muscles. And you may think it's kind of weird to go to physical therapy for that. But I always tell people, if you had knee pain, you would go see a physical therapist. So for, bladder or, bowel problems, going to see a physical therapist works too. Additionally, I always talk to patients about how you can make adjustments yourself, such as changing when you drink fluids or what kind of fluids you're drinking, et cetera. And then the other part of the kind of, once you get past those conservative options, I like to talk about medications. There's a lot of different medications. There's some, a common one is oxybutynin or myrbetriq. Those are medications that help relax the bladder or relax the urges you have to urinate. So a lot of times we try those medications first. The medications do a couple things. One, they often help a lot of patients. And two, they also help diagnose overactive bladder, because if I basically prescribe an overactive bladder medication and you get improvement on it, that's a clue to me that that's what your problem is. So sometimes medications can be used not just in treatment, but for also diagnosis. Because one of the downsides about medications is it doesn't actually fix the problem. It just improves the symptoms while you're on the medication. So that's often where a lot of people stop, because beyond that, it requires specialized training. And I was fortunate enough to train at a center where I had specialized training in multiple different, sort of options. So if we try multiple medications and we fail, there's 3 categories of advanced therapies that are in the guidelines for the American Urology Association. We're going to talk about sacral neuromodulation, that's what Exonics is. There's also percutaneous tibial nerve stimulation that we call PTNS for short. And then the last one is Botox. That's basically injection of Botox into the bladder, which we're going to talk a little bit about as well. Now, for urinary retention, we talked about that again. That's not completely emptying your bladder. That's going to be kind of similar. I'm going to basically take some history. I'm going to do a scan of your bladder to see how well you empty. I might do some additional tests on your bladder function to see if it's squeezing well, if there's obstruction. So I'm going to do some additional tests. And then as far as treatment options go, a lot of treatment options for urinary retention start with lifestyle modification, meaning we do things like have you double void, which means you go to the bathroom once, wait a few minutes, and don't go to the bathroom again, try changing position, etc. For men, we have some medications that we can use for the prostate, but unfortunately, for someone who is not obstructed and has poor emptying, there's not actually medicine that really helps the majority of patients in this situation. So this is where we often can go to advanced therapy or more invasive intervention. Exonic sacral nerve modulation has definitely an indication here. And another option we have is some patients we have catheterized every day. And what that means is to take a small little tube and put it in the bladder to drain the bladder multiple times a day. That's very, sort of life-changing when you have to do that, because you have to carry catheters everywhere you go. There's a risk of infection. So there's a lot of problems with that. But basically, urinary retention does have less treatment options. Now, for fecal incontinence, it's a little bit similar to overactive bladder. We start with a history. The history is very important, for when these symptoms are happening, how often. We sometimes will do some imaging. We do some diet, some diet sort of counseling where we talk about what you're eating and if there's certain things that trigger it. We go through that. We definitely do pelvic floor physical therapy quite a bit, because if you can have a stronger pelvic floor to hold in stool, that can help. We also talk about medications like Imodium and things like that can firm up your stool. But again, beyond that, there's not a lot of, other treatment in that sort of initial realm. We then again move on to advanced therapy, which includes axonic sacral nerve stimulation or surgery. Now, we talked about a lot of these, so I'm not going to belabor all these points, but the two kind of things I want to emphasize a little bit more on the bottom here is the medications. So I often will start with a medication, again, to help diagnose and treat the problem. So the one category on the left is we call beta-3 agonists. Those help the bladder relax. That's a medication like Myrbetriq or Gemtesa. On the right is the category called anticholinergics. These basically block your bladder from contracting. This is something like oxybutynin or trospium, ditropan. Now, these medications unfortunately have a lot of side effects, which is what one of the problems is with them long-term. The first category, the beta agonists, these cause high blood pressure. So one of the problems I struggle with when I prescribe these to patients is when they help, I'll often hear a patient explain to me, well, the problem is I'm already on three medicines to lower my blood pressure. I can't take a medicine that raises it. Or when they started, it causes a blood pressure problem. So that can be a problem in a lot of patients on beta agonists like Myrbetriq or Gemtesa. And then on the anticholinergic side, these medications have been around a long time, but they have a ton of side effects. Side effects like dry mouth, constipation, confusion, difficulty emptying your bladder. So that's one of the problems with these medications for this condition, because a lot of times they have side effects and you have to stay on the medicines long term. Now, for the advanced therapies, this is where we're going to get into detail with them. So the PTNS I told you about, this is percutaneous tibial nerve stimulation. I always tell patients this is sort of like acupuncture for your bladder, okay? This is a treatment we do in the office. It's very minimally invasive, so that's one of the big benefits of it. We take a very, very, very small little needle, and we actually put it in the ankle, and actually put it into one of the nerves in your leg. And believe it or not, somehow the scientists that studied this figured this out, that nerve actually sort of goes all the way to the spinal cord and kind of crosses with the bladder nerve. And essentially what we found with this technology is we can stimulate that nerve at the level of your foot, and it actually can help your bladder symptoms, and it does help for real. So this therapy, the benefit of it is very minimally invasive, but the problem is it's very time consuming. You have to go in every single week for 12 weeks in a row. Each session takes about 30 minutes. And then after that, you then have to do sort of a maintenance thing where you go monthly for long-term maintenance. So it's a little bit of a time-consuming treatment, but I'll tell you who it's really great for. It's for people that have failed medications. It's for people that are a little bit high risk for any type of procedure or surgery, or on a lot of blood thinners that they can't come off. There are some great indications for it, especially because there's not any direct side effects. Typically what I found in my experience is, I'll get a benefit for about 30 to 50% of patients that try this therapy. Now, the next one is bladder Botox, or technically it's called chemo deinnervation of the bladder. So everybody's heard of Botox, right? People get it injected to their face to help with wrinkles. So what Botox basically does is it makes the bladder, or it makes a muscle relax. So that's why people inject it into their face, because it makes it so the muscles in their bladder can't form a wrinkle, or excuse me, muscles in their face can't form a wrinkle. So what we essentially do is use that same principle, and we inject it into the bladder. So this is a procedure we do with a scope in the office setting. It's a pretty easy procedure to go through. It takes about 15 minutes. My portion of the procedure takes about 5 minutes, but we give you some numbing medicine and everything, so it takes about 15 minutes. And what I do is I inject small amounts of Botox at multiple points within the bladder. For me, I usually do about 12 points. And then what it is that medicine is in the bladder, and it causes some of the muscle of the bladder to be sort of relaxed, deinnervated because of the Botox. Now, so that works really well because it does work. One of the disadvantages of Botox is that it is a procedure. So there's a small risk of like urinary tract infection. It only lasts typically 6 to 9 months. So what I found is a lot of patients that get good benefit from Botox, I put them on a cycle, basically every 6 to 9 months. As soon as it starts to wear off, then we set them up for another procedure, and it's kind of a recurring thing. So it doesn't work nicely. It just requires multiple retreatments. So that's kind of what that treatment is. Now, one of the disadvantages of Botox is that it can cause some urinary retention, meaning it relaxes your bladder too well. So I've had a small portion of patients, especially men, have to actually use a catheter after Botox because their bladder is too relaxed. But it is a very effective treatment. It essentially almost helps everybody that has any type of strong urgency or overactive bladder. But again, it has to be repeated. Now, sacral nerve stimulation, and modulation with Axonics. Basically, this is a therapy that actually modulates or kind of controls the nerve activity that goes to the bladder. So without getting too deep into the science of it all, our brain has nerves that go down and control the body, and all those nerves go through the spinal cord in your back. And then when those nerves come out of the spinal cord, they go to all parts of the body. So they go to your arms, your legs, your organs, et cetera. And that's how the brain controls everything. So the nerves for your bladder are actually right there by your tailbone. This is something we figured out a long time ago, but with this therapy, we found that we can actually do a little stimulation of that nerve to the bladder. And we can make it more active, less active. We can modulate it any way we want. And that can actually control those impulses that cause overactive bladder. So just to kind of recap on what I said, in the beginning about overactive bladder, it's kind of the nerves to the bladder kind of going overactive on their own without, control from the brain. So what this therapy aims to do is actually calm that overactive nerve that goes to the bladder down, and that then reduces your symptoms such as urinary urgency, urge incontinence, urinary frequency. Okay. So when we start with Axonics, sacral neuromodulation therapy, we always start with a trial, like a test. We don't want to just put in this device without knowing it's going to work, right? So basically what we do is we always start with a stage 1 or an office procedure to try it. It's a test run. And that's what's so nice about this therapy is you test it before you have it forever. And then that way, we're going to know if it works or not. So we do a trial. And if you get good benefit, then we put the permanent device in. And this permanent device, you can kind of see on the screen there on the left. It's very small. It's like an inch long. It's very light. It's like, I don't know exactly how many ounces, but it's incredibly light, incredibly small. And I always tell people to think of it like a pacemaker for the bladder. So essentially what we do is, if the test works well and you're really happy, then we put the permanent device in, the implant, and this goes in an area kind of near your buttocks at your belt line. It goes under the skin, actually between the fat and the muscle. So, if you really dig around and push on your back, you could feel it, I guess, but it's not something you'd be able to tell anybody had. Everything's internal. It's not something you feel long-term or anything like that. Now, this therapy we put in, this device lasts a long time. And if this is right for you, we have options that have longer lasting battery, or we have rechargeable as well. And the new device just came out, which is one of the things I like about Axonics is they're always innovating and creating new and improved products. The new device has a battery that lasts like 15 plus years. So it's something that's really a long-term fix. Now, basically, Axonics therapy is indicated for all 3 of these things I talked about: overactive bladder, urinary retention, and fecal incontinence. Now, again, the goal is to restore the normal communication between the bladder and the brain, or the bowel and the brain. And again, that's because those nerves are acting on their own. So the goal here for this therapy is to improve the symptoms that happens because of that. So when we do I want to talk a little bit more about the test period, because that's one of the things I think, again, is really the best part about this is the test. We think about all these other things we treat, whether it's enlarged prostate, kidney stones, erectile dysfunction, low testosterone, all these things. very few things do we have a test where we get to test the treatment before we do it. So that's what this sort of is talking about here. So the test system, what we do is we put in a temporary lead. This is a very, very small little wire, which goes through a teeny little poke in the back that goes to the nerve for the bladder. And we use we have some tools to help us get to that nerve very safely. And then the wire actually will come out of the skin when we do the test, and it's hooked up to a temporary sort of stimulator. Okay. And that's something you wear on a belt. You can't tell it's there. It's very small. And basically we have this little remote control that, is there that essentially allows you to turn up the power, turn on the power, and kind of control it. And one of our team members, clinical specialists, work with you very closely to help you kind of work with it to make sure it works. That's one of the things I really want to emphasize. Again, with this therapy, the team members we have in our area here are incredibly effective with helping you work with this, so you're not stuck on an island with this device that doesn't make any sense. So we set that up, and then you do the test period, and we monitor your symptoms very closely. Then if you decide that you like it and you want to get the therapy, this is a little bit more information on the batteries. Now, these are the prior batteries. The new battery literally came out like a week ago. The one on the left is a rechargeable device, and the rechargeable device, the new one, you only have to recharge every 3 to 6 months. You wear a little pack for an hour. It's very minimal. And this device lasts for 15 plus years. The non-rechargeable device basically is a little bit better for some patients because you don't have to worry about the charge. And it typically lasts 10 to 20 years, depending on sort of the severity of the symptoms and how the device was placed. If you're a little younger and you're like, well, I'm only 40, I don't want to have something that's going to die after 15, 20 years. Well, the thing is if you are on the younger side, these are things the batteries easily replaced with a small procedure. So that's something I've done in the past for patients when they've had a battery that's been in 10, 15 years and it's no longer working because the battery's worn out. Then we basically do a small procedure, change the battery, and then, it's good as new. That's another 15, 20, 30 years, depending on what the battery technology is at the time. So those are the two devices. Now, this is a good reference for how small it is. Like I said, it's basically an inch. This is an actual size of a quarter and compared to the device. So you can see the device is very, very small. And when you see me in the office, I have test ones I show you. You can hold it in your hand. It's very, very discreet. Now, the other thing about the Axonics device, which I really like, is that it's compatible for MRI. Historically, sacral neuromodulation has not been able to be used for MRI scans, and Axonics was actually the first sort of device of this kind for the bladder that came out that could work in an MRI. And now just to give you a little background on that, in MRI scanners, you can't have certain metals go through, or you can't have an MRI. So if you're someone that has spine or back problems or hip problems or any other thing where you need an MRI, traditionally you couldn't get this therapy. But the good news is now you can. These are completely MRI safe from Axonics and any type of MRI scanner. So that's a huge benefit. Now, again, there's a small remote control that helps control the device. This is something that's very easy to adjust. And again, our clinical specialists work with you very closely to make sure you understand how to use it. Now, changing the system basically, or charging the system, excuse me. So like I said, this is a little pack, what it looks like. It's something you just wear. It takes less than an hour. You just watch a TV show at home while you're wearing. You don't have to take it anywhere. The new battery, actually, the one that just came out, you don't have to charge once a month. You charge it much less frequently. So that's if you choose the charging system. It's very simple to use. And kind of you can see in this picture here where this patient has that little white charger at, that's kind of under the skin where the device would be. So you can see it's kind of at the belt line on the buttocks. Now, this is almost, this is just a little data about sort of how patients felt about charging after they had it for 2 years. And you can see 94% of patients thought the charging duration was fine, acceptable. And then basically, 98% of people are charging every 7 days or less, frequently. So you can see the charging is if you choose the charging option, it's something that's very easy. Now, and again, this is the key here. You basically just do it while you're sitting at home doing something else. It's not something you feel, or it's a very simple process. Now, this is the key thing I want to talk about, is because a lot of patients I have that I counsel on this therapy, they're like, oh man, that sounds crazy. Like am I really gonna put in a small device? Well, the thing about it is 93% of people at 2 years, meaning with good duration, have significant improvement of their symptoms. So what significant improvement means is that doesn't mean just like, oh, if you had 6 leaks a day, now you're 5 leaks a day. That means that like between some people who got it and people that didn't, there was actually a measurable difference with all the statistics and everything. So 93% had significant improvement, which is huge. And that's 2 years out. That's not just like the first week. And the reason we're so successful with this, again, is because we do a test. We don't put the therapy on anybody that it didn't work. Now, the majority of people we test, I'll admit, almost everybody that I test wants to do the permanent implant because they get a huge benefit in symptoms. I had a patient recently that said she was waking up every 2 hours for the last 10 years because to urinate, and after the first night of the test, she slept for 10 hours straight for the first time in 10 years. So, the majority of my patients want to put the permanent one in, but you can see that the reason we're so effective is because we do the test. Now, again, a little more on the similar, and this is, I think, the second one I really like to emphasize. 94% of people said they were satisfied at 2 years, but 93% of people said they would do it again. So that's like a key thing. I always ask people about anything, whether it's medicine or anything in life. Would you do it again if you had to go back in time? And 93% of people said they would do it again. And I think that's huge. And again, it really just improves your quality of life. So many people I find have these bothersome urinary symptoms. They feel like they're stuck with them for the rest of their life. And this can change your life for the long term. And that's where I think it's many patients should consider this type of stuff. Now, I want to talk a little bit about stress urinary incontinence. And again, this is when you leak urine because of some type of pressure in your bladder. So coughing, sneezing, exercise, laughing, things like that. That could be what stress incontinence is. So I talked a little bit about it is, the normal bladder function. Your bladder is supposed to store urine. And then when you want to urinate, you relax your sphincter and contract the bladder. And that's how you urinate. Now with stress urinary incontinence, you can see on the picture there, on the bottom left one, you can see that the sphincter is weak. It's open. So that's what causes leakage of urine during physical activity, because that physical activity causes pressure on the bladder. So that's not normal. You're not supposed to leak urine because you cough. If that happens, that's what stress incontinence is. And the thing I'll tell you is that's something that's actually very fixable. And I'm going to talk about that in detail. And again, you're not alone. This is one of the most common things women struggle with. Now, and again, this says 1 in 3 women. I would even say it's probably more than that if you count women over 40. It's just so many women, again, feel like it's just something that's a part of being a woman, and that's not correct. Now, this is a key thing. 60% of women say the symptoms of stress urinary incontinence impact their quality of life. So what would that be? Mental health. So this is like people don't want to do things, or they're anxious about being wet all the time or smelling like urine. Physical health, it can cause rash, other kind of problems in the groin. Again, productivity, economic, meaning economic is talking about money spent on pads and diapers and things like that. So there's a lot of impact on their quality of life. And I'm going to talk about some of the treatments here. So basically there's 3 kind of treatments. Now I always start with the top, and then kind of where you go from there depends a little bit on each individual patient. Now, basically with pelvic floor physical therapy, as I talked about, that's a specialist you go and see that I refer you to, that it will help you strengthen your pelvic floors. That's pelvic floor muscles. And that's huge. That helps quite a bit of women and men. Then from there, we talk about intervention. And it used to be really surgical sling was really the only option. And surgical sling works really well. But the thing about it is it's a piece of mesh or a piece of tissue that we harvest from your abdominal muscles. And basically we kind of lift up your bladder at the urethra. But the problem is it has a lot of potential side effects and risks. And it requires, it's a surgery, general anesthesia. So it's a lot more invasive. And what urethral bulking is something that we have a procedure that really helps with that, and it's called Bulkamid, which I'm going to talk to a little bit more about in detail. Now, just to recap, give you a little more information on these pelvic floor exercises. These are what you hear about traditionally called Kegels. Kegel is a term where you kind of flex the pelvic floor muscles. And the reason I'm a big fan of sending people to pelvic floor physical therapists is because I find that the majority of people don't know what a Kegel is. So when I do an exam on a man or woman and I say, okay, go ahead and do a Kegel, and that patient thinks they're doing a Kegel, but I can feel the muscles and they're not squeezing. It's kind of hard. It's not intuitive. It's not easy to know what it is. So a pelvic floor physical therapist helps you kind of learn those things. Now, again, we talked about the sling. The sling is very effective, but the problem is it can cause urinary retention. It can cause erosion, irritative symptoms. There's a little bit of risk to it. Now, granted, a patient that comes to me that has significant incontinence, stress incontinence, like, really bad 5, 6, 7, 10 times a day, a sling might be the best option to go with because it's very definitive. And then one other thing to consider is it's not a great option for younger women because it's a little bit invasive. And if you still are considering pregnancy, having a sling, if you get pregnant when you have a sling, it's not a problem for the pregnancy, but it will totally loosen the sling and make it not effective anymore. So urethral bulking agents, that's what we're going to talk about next, have been around for a while, but they haven't quite been as effective as they are now. But what it is it's a small procedure we do. And what I usually do is with a scope, I take a look at your sphincter, and I basically, right around the area of the sphincter, you can see in the picture there, the areas of blue, I inject the sphincter, which is, the thing that controls urine, right around it with this agent called Bulkamid that basically sort of bulkens it, strengthens it, makes the opening narrow. And what that does is that makes it so urine can't leak through as easily. So what I do it very precisely, where under the scope I can see directly, and I inject enough at 4 different points, if kind of around the clock. And I do it to the point where I can see that the urethra closes just enough. That way your urine won't leak on its own, but that you can still urinate. This is something, that takes me less than 3 minutes usually. It's incredibly effective and it works right away, which is the benefit. So you go home the same day from the procedure and you already have benefit. Now, so this is something, again, this allows you to actually get out there and exercise and do those things. So just to talk a little bit about what Bulkamid is, what we're injecting in you, it's basically a water-based gel that has strong evidence that it actually can help sort of strengthen this area without any kind of long-term scar, fibrosis, complication, anything like that. And I've kind of talked about this one already, so I'm going to skip through this one. And this is what I was talking about a minute ago, where I do it around the clock. You can kind of see in the picture on the bottom, the openings in the middle, and I inject it in 4 points around the clock to make that opening to the bladder very narrow. So this is what the Bulkamid procedure does. It takes less than 5 minutes. And I always tell patients, think about it like it's like a filler, like same thing like a facial filler, and it doesn't cause any kind of adverse reaction. So it is really nice. And again, the thing I like so much about it is that it's very minimally invasive. It's as a patient, you almost have no sense it even happened. Your risk of the procedure is incredibly low. There's a very, very small risk of urinary tract infection. You might have like a little bit of bleeding, like spotting for a day or two for women, or maybe a little blood in the urine for 1 day for men. It's in the vast majority of patients we do it on, 92% of women reported being cured or improved. And the procedure, basically the thing lasts a long time. Bulkamid, we have evidence that it lasts in a lot of patients for up to 7 years. I find a lot of patients will get benefit 3 to 5 years, up to 7 years. The thing about it is it's so minimal that if you don't get benefit, if it lasts only 4 or 5 years and you need to have it done again, no big deal. It's another 5-minute procedure. And basically, the other thing that's nice about it is if you try it and it's not quite as effective, it doesn't preclude you from other therapy. That's one thing I've noticed with the previous type of bulking agents is it made doing a sling a little bit harder. So if you end up getting the Bulkamid and it's not exactly enough to help you, then we still can go on to the more advanced therapies. So basically, my question for you is, are you ready to actually improve your quality of life? So to get started with this, basically what I'd like, I'd encourage you to do is schedule a consultation with me to determine where you're at with overactive bladder or urinary incontinence. And we can, I'm going to do a thorough evaluation, start you on conservative medication. If you haven't already done that, consider some medication and talk to you about the options. And again, with Axonics, I like to get patients to do the nerve trial as soon as we can, because the nerve trial, again, it's like you get to test drive a car, which the majority of things in medicine, you don't get to test drive. So that's basically my presentation today. Ali, I'm going to turn it back over to you.
Yeah, thank you, Dr. Fisher. It was a pleasure hearing from you and your experience with treating patients suffering from these conditions. So I'll start with some of the questions. Is this procedure covered by insurance?
So yes, this procedure is typically covered by insurance. It's covered by Medicare and the majority of mainstream insurances. Typically, when we treat any condition in medicine, a lot of times insurance companies will want us to make sure we've tried other therapies first. So usually when I see a patient with these type of things, when I take your history, I find out what you've tried and what you haven't tried. And then I go through some conservative therapies or some medications first. But as long as we kind of go through and try the first and second line therapies, then this procedure is covered by insurance.
Okay, where is the trial test done?
So the trial test we typically do in one of two settings, and it depends on you as a patient a little bit. The main place we do the trial is in our procedure center. We have a procedure center here at Georgia Urology that's kind of like just a doctor's office, but it just has some extra equipment like an X-ray machine and things like that. You'll come into that. It's in an outpatient setting. We basically have you come in, do the procedure. The whole procedure, as far as my portion for the test, takes about 15 minutes. But getting in, positioned and cleaned off and everything can take a little longer, but it's done in our procedure center. Although some patients, we actually will do the test in the operating room. And the reason we do it in the operating room is basically just because sometimes we like to do a little bit of sedation. The reason that's important is because, for one, some patients, are obviously a little anxious about having a procedure done awake or anything like that, even if it's well tolerated. So I like to do patients that are anxious about that in the operating room. And then the other time is some patients actually have an indication where I want to do a little bit of a longer test. And if I want to do a longer test, like with fecal incontinence or urinary retention, then I often will do it in the operating room because I can place a longer term test lead rather than the shorter one. So we can do it in the operating room or in the procedure office setting, depending on sort of when we discuss it together.
Okay, and this one, yeah, you should be able to answer. My OAB is a condition of my Parkinson's disease. Is Myrbetriq the preferred medication?
So Parkinson's disease, I'll admit, is one of the more complicated types of sort of urinary symptoms to treat. Now, a lot of times with Parkinson's disease, it actually relies a little bit of what I call sort of trial and error with some things. So I do think Myrbetriq is a good option to try for Parkinson's, and that's often the first thing I like to do. Anticholinergics are not a good option for Parkinson's because Parkinson's a lot of times, again, without getting too deep into the science of it all, has certain neurotransmitters that are high and low that can play a role. And basically, in this situation, those anticholinergic medicines can affect that access and some of the other therapies. So Myrbetriq is a good option, but Myrbetriq doesn't always work. And what I'll tell you is third line therapies such as Botox or sacral nerve stimulation with Axonics are great options for patients with Parkinson's to try. I don't think PTNS, that acupuncture on the ankle, works well for Parkinson's, in my opinion. But I have a lot of patients with Parkinson's that I'm able to get dry or improved with medication, and then also some patients that require advanced therapies that I can improve.
I have a good question. We like to hear this question. How is this better or different than the Medtronic implant?
That's a great question. So in my training, I was fortunate enough to do Medtronic InterStim and Axonics sacral nerve stimulation. And, again, just as a clinician, there's ultimately the ultimate effect of the therapy is going to be very similar. They both have a similar technology that sort of not modulates the nerve. Both are reputable companies, et cetera. The reason I particularly as a clinician usually, recommend Axonics is because Axonics has had significant innovation in their product, which I tend to find very effective. So for example, the Medtronic device I used to struggle with for a long time as a urologist because it was not MRI compatible and there was not a rechargeable option. So when Axonics came out, they developed that right away while Medtronic was still waiting to develop it. So that opened the door for so many patients that needed an MRI compatible device. And then the other thing I really like personally about Axonics is the clinical support team that we have in this region is second to none. When you're going through your test, before your test, after you have the permanent device, if there's something going wrong, the clinical specialists here they are so available to help. Help you troubleshoot and figure out how to get things right. It's incredible for patients. So that's personally my sort of thoughts on the advantage of Axonics. But Medtronic InterStim is a good device too, and it works very similar.
Okay. I'm currently taking medication for my OAB. Is this something that I'll have to stay on my whole life?
Okay, so that's a great question. So I have a lot of patients that will come in and they'll get good benefit from something like Myrbetriq. But then they realize that they're getting a little bit of high blood pressure from it. And they always ask me that. They're like, oh, does this actually fix the problem? And what I tell you is it's really, you should think of it like a Band-Aid. It improves the symptoms, but it never actually truly fixes the overactive bladder itself. So it's a medicine you actually have to buy into for life. So if you're 45 years old and getting benefit from Myrbetriq, you're looking at 40 or 50 years of being on this medicine. And that's where I encourage you, if you're on a long-term medicine like that, is you really want to try and come up with things that can actually fix the problem rather than just add a medicine. Because what happens to most patients as you get a little bit older, you tend to develop other medical conditions, whether it's high cholesterol or high blood pressure or diabetes, et cetera. And all these medications start to build up. You end up being on a long list of meds. And then what happens is these different medications interact and have side effects that interact, et cetera. So that's why I often encourage people, even if you're getting benefit from a medicine, that you should really consider sacral neuromodulation with Axonics, because it actually fixes the problem, and then you don't have to be on the medicine. So then you don't have any side effects from the medicine. You don't have to take a pill every day for the rest of your life. So anytime you can eliminate a pill for life, that's good. And to answer your question, yes, if you're on the medication, yeah, you'd have to be on it for life.
Okay. And this one should answer one of the questions we got. Is this for both men and women? And is there an age limit?
Okay, great question. So this is absolutely for both men and women. I find that it's a lot of sort of, primary care doctors and urologists even will often quickly blame urinary symptoms in men on the prostate. But I find a huge amount of men that actually have overactive bladder that have thought their whole life they just have an enlarged prostate. I try to do a thorough evaluation of your bladder function, your urinary control, et cetera, to help understand that. But I have many men that I get great benefit for. Anytime you do any type of procedure, you always want to think about sort of risks and benefits. Now, Axonics therapy, the test or the actual implant, are both low risk procedures. The implant is what I would call is about a low risk surgery as you can do. In fact, I can even do Axonics nerve stimulation under straight local anesthetic without any anesthesia at all. However, there's certain times you got to think about it. If you're 98 years old, it's probably not a great idea to do any type of invasive procedure. But I have plenty of patients, in their late 80s, early 90s even, that can benefit from this procedure. So no, there's not a strict age limit. Sometimes there could be some complex medical comorbidities that can play a role. But again, this is something I can actually do in the right patient under straight local anesthetic without any general anesthesia at all.
Okay. And do any of these treatments address repeated UTIs?
Yes, a little bit, depending on the cause of your UTI. So UTIs, meaning urinary tract infections, and that a simple urinary tract infection usually involves infection of the bladder. So infection of the bladder can be caused by a lot of things. And one of the things that can cause it is urinary retention. Urinary retention basically means you're not emptying your bladder all the way. So that urine just sits in the bladder, it doesn't drain out, and it can cause an infection. So if you have any kind of urinary retention, or if you have any kind of urinary tract infection, one thing I always evaluate for is UTIs, is urinary retention. So I check for that in the office. And if you have urinary retention, one of the ways we sort of fix your UTIs is by fixing your retention. So in that situation, yes, this can help UTIs in some patients. However, if you empty your bladder pretty well, this doesn't have a huge impact on UTIs. But I will tell you, there's a lot of other things that I do to help women or men with recurrent UTIs, that involve therapy beyond these overactive things, like for women, which may include vaginal hormones or things like that. So I've got a lot of things I can do for that. But in some patients, yes, this can help recurrent urinary infections if it's from urinary retention.
And looks like we have time for one more. So this is a Bulkamid question. Will the injected gel change its position?
So basically what happens with the injected gel is I inject it, sort of under the mucosa, which is the sort of surface layer of the urethra at 4 points, sometimes 5 points, sometimes 3 points. It's a little bit of a game time decision how things look. My goal is visually how it looks. Over time, that does shift a little bit, and that can happen. Now, and that's the reason why it doesn't last 100, it's Bulkamid is something that's probably not going to last 40, 50 years. But the idea is it does last several years. And the reason it probably starts to wear off is either one, slight movement of the Bulkamid material, or two, just further weakening of the pelvic floor or urethra. But in my experience, the durability of it is pretty good. We're looking at, again, 3 to 7 years is what I tell most women. And if it works well, and then we have to do it again, the thing is, it's such a minimal procedure that it's very easy to do it again.
Okay, and that brings us to the end of this evening's webinar. Thank you, Dr. Fisher, for your time. We hope the presentation was beneficial. If you'd like more information or to schedule an appointment, please call Dr. Fisher's office or utilize the QR code on the screen to utilize his self-scheduling platform. Please use the code webinar event for access to reserved slots. Thank you for joining us, and we hope you enjoy your evening. Thanks again, Dr. Fisher.
Thanks everyone for joining. Thank you, Ali. I really
All right.
appreciate it.
Good night.